We are very excited to have Dr. Jennifer Kogan teach us a bit on medical education for both our residents on wards, and she's an invited guest lecturer from our clinician educator track, our MACE track here at Georgetown, which is in its second year, so we're excited. Dr. Kogan, she began her career at the University of Pennsylvania School of Medicine, where she graduated AOA, and then she remained at Penn to complete her residency training in internal medicine. And from there, she, as we just were talking about, completed then a clinician educator fellowship, where she gained additional skills and interest in this forum. And so she has remained, it seems like you're a Philly lifer, as a professor of medicine there. And she directs the MEASY Medical Education Fellowship and has been the clerkship director previously as well. In addition to all of that work, she is a general internist at her clinic and has completed extensive research on medical education, particularly focusing on feedback and competency assessment. And so we're just really excited to learn from you today and some of our first, second, and third year residents who are all interested in medical education.
Great. Well, thank you for that very warm introduction, and I am excited to be with all of you today. I'm gonna kind of give you a talk about direct observation of clinical skills, but you know, it is fine to stop me along the way. I'm gonna kind of ask some questions as we go to make Zoom as interactive as it possibly can be. It won't quite be in the venue of like a workshop. It'll definitely be me doing a little bit more talking, but there will definitely be points in time where I would really value hearing your thoughts about certain issues. And then if there's anything that I'm saying that like doesn't make sense, or you think about it in a different way, please just either pipe in or put it in the chat, and somebody will be like calling out the chat to me, and I'm fine to stop anywhere along the way. So questions are really good. Let me give you a roadmap for what we're going to cover in the next hour. We're going to talk about direct observation of clinical skills. And in order to do that, we're going to do a quick review of competency-based education and workplace-based assessment, just to make sure we're on the same like playing field in terms of our understanding of these terms. We're going to briefly talk about why direct observation is so important in medical education, what some of the challenges are, and then I'm going to share with you at the end of this talk some ideas about how you can improve both the frequency and the quality of the direct observation that you do with learners. So we're going to first start off by just talking about kind of the context in which this is all occurring. And so we have to spend a minute or two talking about competency-based education and workplace-based assessment. So as many of you know, some of the key sentinel events in medical education that has impacted medical education are the two IOM reports, To Err is Human and Crossing the Quality Chasm. And what made these two publications so sentinel is that it illuminated in a very significant way how dangerous it is to be in a hospital, and how much excess, both morbidity and mortality, there is. And in these reports, there was actually a call to the profession that we needed to do a better job at self-regulating ourselves. And that part of our professional responsibility was to ensure that the individuals that we graduate can provide high quality, safe, effective, patient-centered care to our patients and their communities. So from this, there was sort of a movement to sort of change the paradigm of medical education to what's called competency-based education. And the definition of, this is one definition of competency-based education. It's an outcome-based approach to the design, implementation, assessment, and evaluation of a medical education program using an organizing framework of competencies. So I don't know about you, but that is like a mouthful of mumbo jumbo. So here is my version of competency-based medical education, which is I taught Stripe how to whistle. I don't hear him whistling. I said I taught him. I didn't say he learned it. So the old paradigm for how we thought about medical education is that you would have a lecture about whistling, You would then do like a sim about whistling. You would go on a whistling clerkship, and then you'd go on a sub-I for whistling. And then just having done all of that, we would make the assumption that you could whistle. What competency-based education is saying is like, yes, we have this structure, we have this process, there's this time. But at the end of the day, what I really need to know is not what did you do, but can you do it? Can you whistle? And that is the sort of key paradigm shift of competency-based education, is it's focusing on the outcome, the competencies, not the process of how you get there. So in this paradigm shift, many things have changed. In its truest form, competency-based education would move us from what we consider fixed length variable outcome training to variable length fixed outcome training. So we all are in what is fixed length variable outcome. You guys are all doing a 3-year internal medicine residency. And the reality is regardless of kind of where your skill set is at the end of those 3 years, for the most part, residency ends. But the reality is there are some of you who probably have your skill set ready and honed at the end of the 2nd year, and you don't really need a 3rd year. And there are probably a handful of people who would benefit from 3.5 years. That would be variable length fixed outcome training. What you will see on this table is that one of the paradigm shifts in competency-based medical education is switching from an emphasis on summative assessment, a very high stakes single exam like the boards, to more formative assessment or feedback that happens in a more frequent way. So this is where workplace-based assessment comes in. So workplace-based assessment is defined as the assessment of day-to-day practice in the authentic clinical environment. So it's really assessing what it is that doctors do in practice. And so when you think about how we assess learners, one framework that we use is something called Miller's Pyramid. And Miller's Pyramid takes different levels of kind of knowing and doing and maps it to different assessment strategies. So for example, if I want to just see if somebody is knowledgeable about heart failure, I give them a multiple choice exam. If I want to see if they can like recognize in a clinical vignette a patient who's presenting with shortness of breath and lower extremity edema and can figure out that it's heart failure, I could give them like a case set. If I want to see if somebody could actually show me how they evaluate a patient with congestive heart failure, I could have a standardized patient. But at the end of the day, what I really need to know is, can you, working in a hospital, in an emergency room, in an ICU, do you know how to evaluate and treat a patient with heart failure? And that's where workplace-based assessment comes in, assessing what it is that people do in practice. And you can imagine as we move up Miller's Pyramid, our assessments are much more authentic, right? Me observing you in the ICU, taking care of a patient with heart failure, is a way more authentic assessment than me giving you multiple choice questions about heart failure. Not only is it more authentic, but it better assesses expertise. Now, in our toolbox, there are lots of assessment tools that we can use for workplace-based assessment, and they can be divided into 3 categories. The first is what are called single event direct performance measures. This is where like I watch you with a patient, or I observe you giving a presentation, or I look at a note. They're like a single encounter. Then there's the global direct performance measures. These are like end of rotation evaluations, and then aggregated measures, which are things like logbooks and portfolios. For the purpose of this talk, I'm really going to focus us here in direct observation of clinical skills. What do I mean by that? So that is observing learners with patients, doing things like taking a history, performing a physical exam, counseling a patient, observing a procedure, or even the skills that don't involve patients, like working as part of an interprofessional team, or how you teach on rounds and engage your medical student. So having defined competency-based education and workplace-based assessment, I'd like to shift us for a moment and talk about why direct observation is such an important assessment strategy in medical education. And what I would love is if you can write in the chat some reasons why you think direct observation is a really important assessment strategy in competency-based education. And then Carrie, maybe I'll have you just read what people write in the chat.
Will do. So one of our words teams is saying immediate feedback. What else you guys got? Uncovering obvious deficiencies. Sometimes people know the vocabulary, but not what it means. And then realistic scenarios. Feedback is more descriptive and accurate. And then relevant feedback.
Awesome. Great. So I think, you know, what's fascinating is the whole reason I got interested in direct observation early in my career is because I was actually really interested in feedback. And I was reflecting on the fact when I was a resident and I was a fellow at that time, I just never felt like I got feedback that was like specific and actionable and like really helping me to like advance my skills. I felt like I got a lot of, you're doing a good job, keep doing what you're doing, read more, everybody can read more. And like, none of that was helpful. And so my whole interest in direct observation actually originated from an interest in trying to improve the quality of feedback that learners get. So I'm going to share with you just a few reasons of why I think direct observation is so important. And actually, the first reason why I think it's important is because I think it is essential to patients getting high quality care. And let me just sort of play this out for a little bit. So in order to get high quality care, we have to have good clinical skills. But there's a whole body of evidence that, you know, sometimes some of our foundational skills, like history taking, physical examination skills, our ability to like collect data and not make cognitive errors, like we're not always so good at that. The second thing that we know is that how we communicate with patients really impacts the quality of care that they get. And what this slide shares with you is sort of all of the ways in which communicating with patients in a patient-centered way improves outcomes for patients. Like, this is not just about being a nice person. These are communication skills that actually can improve patient adherence, improve their outcomes, and decrease their costs. So we know that skills like history taking, clinical reasoning, how we communicate are really important to care quality. What we also know is that how people perform these skills is variable. So there was work done actually at the University of Michigan where they had all of their incoming interns do like a standardized patient assessment. And there have been studies done in surgery as well, which show that there's a wide variability in graduating medical students' core clinical skills at the beginning of internship. And this variability isn't just in learners. This variability exists in attendings and practicing physicians. There's work that's been done that shows that cardiac auscultation skills don't improve after the third year of medical school. And Clarence Braddock has done some work that many practicing physicians, when they are counseling patients, don't actually engage in the required elements of shared decision-making. So if our goal is to really ensure that our patients get the best care possible, and if we know that performance is variable, then this is where we as educators and supervisors come in, because what it means is that our job when we're working with learners is we have to fill in the gap between what it is that learner is able to do and what a patient needs to get high quality care. And I would argue that it is difficult to know what gap to fill if you haven't observed somebody in practice, right? If you just make a guess at it, you either are going to overestimate somebody's skill level, which is going to be a detriment to the patient, or equally as problematic, you may underestimate somebody's skills. You might jump in too soon and micromanage, which can actually prevent the development of a learner's autonomy. So if you want to titrate supervision to both what your learner needs and what a patient needs, it has to be informed by good data, and that data is observation of learners. The second reason why direct observation is so important is that this is the learning cycle. And what you can see is that ideally we set goals, we observe performance related to those goals, and then that becomes the basis of feedback. And you guys all mentioned that one of the important reasons for direct observation is to actually get that really specific feedback. And so just to sort of drive this point home, take a look at these individuals and tell me, what is it that you think they have in common? Somebody just shout it out.
They have a coach.
They all have a coach, right? They're experts, they have a coach, they practiced a lot. I once did a faculty development workshop and I asked the question, and the first thing somebody said was they make a lot of money. And then somebody else is like, oh, and they're genetically predisposed to be wonderful. And I was like, ooh, not quite where I was going. So yes, there probably is some innate talent. Many of these individuals were quite wealthy, but exactly, Carrie, these are individuals who had coaches and they practiced a lot. And so where does direct observation fit into all of this? Well, what we know is that in order for individuals to develop expertise, it's not just practice, it's deliberate practice. And these are the elements of deliberate practice. And what you can see is that deliberate practice requires informative feedback. And the reason you need that feedback is because our self-assessment isn't always accurate. So I'm sure that many of you have worked with medical students who they look in the mirror and they see a lion, but they're really kind of more like a kitten. And I'm sure you've also worked with people who have like imposter syndrome, who they look in the mirror and they see a kitten and they're actually a lion. So part of developing expertise is getting external feedback so that you can calibrate that self-assessment so that you can continue to improve. And this graph, this picture shows how individuals develop expert performance. And what you can see is that what enables individuals to achieve expertise is that they remain in what's called the cognitive and associative phase of learning, where they're kind of always thinking about what it is they're doing and adjusting. And the way that they are able to do that is they set performance goals a little bit beyond where they're currently performing so that they're essentially always practicing. What happens when individuals plateau in performance is they stop thinking about what they're doing. My guess is that on most days, many of you have stopped thinking about like the actual act of taking a history. It's autonomous, you just do it. But if you really want to improve your history taking skills, you need to be like really actively thinking about what is it that I'm working on? How do I want to be more patient-centered in my communication? And then you get yourself back into this cognitive or associative phase of learning where performance can improve. And if you haven't read the article that Atul Gawande wrote in the New Yorker in 2011, I think he does an amazing job sort of talking about the value of observation. So as you know, he's a surgeon in Boston, and he was reflecting on the fact that his operative morbidity rate had plateaued. And he was thinking about how, you know, athletes and musicians, even when they're experts, they continue to have a coach. And yet when we finish training, we don't get coached anymore. And so he describes contacting one of his surgical mentors to scrub into the OR with him. And he's doing, I think, a thyroidectomy. And he's like, I've done like thousands of these before. And he says, you know, it went beautifully. And then he sits down with this observer, and the observer points out to him all of these opportunities for improvement. Everything from how he draped the patient, how he engaged learners in the operating room, to even how he was like holding his arm while operating and how that could affect surgical precision. And so I think this article is just a great way to highlight how we all have blind spots. And if we all want to continue on our own journey in self-improvement, people have to watch us so that they have good data to give us feedback about. And so, you know, this is just another way to say, if you want to coach, you've got to observe, right? If you think back to when you were an athlete or when you had music lessons, your coach was watching you. They weren't like down the hall in the coaching room and you would go down and like sort of say how you landed a double axel, and then they would ask you some questions and send you back again. But a lot of what we do in internal medicine, right, is like we send learners out, they do something, and they come back and they report to us. And we learned some things about them, but you can't learn about how somebody clinically reasons and takes a history, performs that physical exam, how patient-centered their communication skills. That's all proxy information. Does that make sense? Okay. And so then the last reason of why direct observation is so important is because at the end of the day, in competency-based education, each of these observations is like a piece of the puzzle. And if you have enough observations, the idea is that you can begin to create a picture of where somebody is in their skill set, their strengths and opportunities for improvement. And ideally, by the time somebody's ready to finish their training, we have to make a decision about whether this individual is entrustable, meaning can they go out and practice this unsupervised, with the caveat that unsupervised with the patient getting safe, effective, patient-centered care. And I would argue it's very difficult to make a good entrustment decision if you're not basing it on good data, and good data is direct observation. So just to summarize this part of why observation is so important, first, I actually think it's a patient safety and quality of care issue. If we want our patients to get good quality care, I think we have to observe learners so that we're filling in the right gaps. Direct observation is important because it helps us as coaches to set goals for our learners so that we help to keep them in that cognitive or associative phase of learning. And then finally, direct observation is important in competency-based education because it helps us to determine in an authentic way if somebody gets the keys to the car. Are they entrustable? All right. So let me just stop there and see if there are any questions before we move on to challenges in direct observation.
I guess one question I have, Dr. Kogan, is I think when you're talking about setting goals, maybe this is something you'll touch on in the future, but sometimes I feel like it can be really hard to set those goals. I mean, you can sometimes try and do that at the start of a rotation when you're working with a group of students or something like that. But sometimes I feel like that's hard to be able to say, this is where I want you to improve, or have the learner identify that themselves. Do you have suggestions?
Yeah, so I will say it's a great question. And most of my interaction with learners at this point is, I have clerkship students who are with me in the office. And they actually, because of the way it's set up, I maybe work with them 3 or 4 times in a 2-week period. So there's not a lot of continuity, which is hard. And I think what I have found to be effective is we set some broad goals on day 1 of what it is that I expect and what they're hoping to work on. And when we are, each day we try to set some goals, and actually before a particular patient encounter, if I'm watching, I either have them set a goal or I ask, what is it that you want me to pay attention to? And I feel like that really narrows it, so that if I'm going to go watch them take a history on a patient, we can focus by saying, all right, I'm going to be in the room with you. What is it you want me to pay attention to? And usually they can come up with something. I may, in feedback, give them more feedback than just what they're interested in, but it's a way to really quickly narrow to a goal. You know, what is it you're working on in your history taking? Is there something you want me to pay attention to in terms of how you manage Epic with the patient and the balance of the computer? Like, so I'll throw out some things if they're not coming up with things. But does that answer your question?
Yeah, that was very, very helpful. Thank you.
All right, so let's do this, and let's, I want you guys to put in the chat what you think are some of the challenges to direct observation. And I'll give you a hint. There are going to be challenges related to the people who do the observation, the observers. There are challenges to being the learner that it's happening to. And there are probably some things about our learning environment that make observation hard. So those are your hints. So throw into the chat for me some of the things that you think get in the way of direct observation, both the frequency, like just having it happen, and then 2, having it be like useful and effective.
We've gotten a couple with time with exclamation marks. And then we are just pulled in so many directions. When you observe something that is unsafe and you have to intervene right away, efficiency, and then maybe putting the student, making them feel like they're put on the spot.
Awesome. Great. So I hear a lot about like logistics of like time. There's other stuff. I will tell you, I've done this workshop a lot. And the number one thing that comes up the first time, every single time, is time. And usually it's in person, so I don't get the exclamation marks, but the exclamation marks are very much appreciated. All right, so you called it, you guys mentioned time. I think one of the challenges, particularly as the person being observed gets further along in their training, is this tension of not wanting to undermine the learner-patient relationship, right? Like if I, as an attending, am going into like a PGY3 patient encounter with one of their continuity patients, there's sometimes this concern that I'm gonna undermine that relationship. And then the other sort of barrier is just around low self-efficacy in the role of the observer. Like I remember when I was an attending my first year and I was watching one of my residents do, it was one of the interns, doing a shoulder exam. And full disclosure, my shoulder exam when I finished residency, horrible, like incompetent at a shoulder exam. So I'm like watching this intern do a shoulder exam, and my shoulder exam is like literally, I'm gonna push in a few places and I'm gonna do this. And all of a sudden I had this moment of like, oh my God, I have to give feedback about a shoulder exam. And like my shoulder exam is horrible. And so sometimes I think part of the barrier to observation is we're asking people to assess skills that they themselves are not comfortable with. Some of the other barriers are just around like having to give that feedback, or like you see something and then you're like, oh gosh, how do I fix it? And then it's uncomfortable. Like, I feel like this person has awkward interpersonal communications and now I've observed it. I don't know how to fix that. And so that can get in the way of observation. From the learner perspective, observation is pretty uncomfortable. Think about the times where you've been observed. And if I were to poll you guys, I would imagine that you guys would write things like it's anxiety provoking, it's stressful, like it was artificial, it wasn't valuable, and all of these things have been borne out in the literature that oftentimes it's like a checkbox activity. Okay, we have to do an observation. You end up getting observed in something that, I don't know, you already know how to do, and it's not very helpful. And then as you guys mentioned, you know, two core values in medicine are autonomy and efficiency, right? And direct observation can be a threat to both of those, as you wrote in the chat. And then the last piece is that there's this real tension between what's going on here. Is this feedback or is this high stakes assessment? Like, is it gonna count? And this is particularly true when you're working with medical student learners. And we can say till we're blue in the face, oh, no, this is just for feedback. But the reality is that if it happens infrequently, it automatically makes it high stakes, right? All right. And then the last piece of what really gets in the way of the quality of this is that when we observe and we're asked to fill out rating scales, everybody's using a different frame of reference or standard that they're comparing the learner to. So oftentimes we give people these scales that look like this, and we put little anchors under them that look like this. But like, what's satisfactory? And we don't define for people what is satisfactory. And so left to their own devices, some people interpret satisfactory as sort of, is somebody performing at expectation? So this is a second-year resident, and are they doing what I think a second-year resident should be able to do? That's a normative frame of reference. So what's a problem with a normative frame of reference?
I mean, for me as a, you know, as residents, right, my knowledge of a medical student my first time as like an intern, I don't, you know, my expectation, what is my expectation? And then I have a different one when I'm a PGY3. So it kind of, for us as residents, will evolve over time. And then again, if it's attending who works with students once every 4 months versus the one who's working consistently, it's really harder to make that assessment.
Perfect. It's totally idiosyncratic how we come up with the idea of like what a PGY2 is able to do. And furthermore, this doesn't really get us to like the patient of like what it is that a patient needs, and how something was done is what was needed by the patient. Fascinatingly, when you ask faculty, well, how did you decide that this was satisfactory? They're like, I don't know, it just felt that way. And sometimes, I mean, that can be very accurate. Holistic assessments that Gestalt can be totally accurate, but what's the problem if workplace-based assessment is based on Gestalt in terms of what's satisfactory? Where does that fall short?
Very prone to bias.
It's prone to bias. If I can't explain to you why I think what I think, it's going to be really difficult to give you specific feedback. Awesome. Okay, this is a really common frame of reference that faculty use. Satisfactory is if you are doing it like how I would do it. And rarely then is it going to be superior, because that would mean that it's like better than what I do myself. So what's the problem with this frame of reference?
Different years of experience somebody put in the chat. And I also think there's just not one right way to do things in medicine. So
right. So it's sort of a combination of, yes, there are some things where there's not a right way to do it, but there are boundaries, right? To like what is and is not acceptable. And, you know, we're not always the gold standard, right? So if like my shoulder exam, if I'm going to compare this intern to my own shoulder exam, like that's not satisfactory. So I think recognizing we're not always the gold standard in the skill. And this is sort of just the elephant in the room of like where we are, that like if we really want to improve some workplace-based assessment, some of it may actually require some faculty development, right? Where there's a lot of us, you know, when I trained, we did not explicitly learn how to break bad news. We did not learn how to do a handoff. We did not explicitly learn how to do a goals of care discussion. We sort of osmosed it along the way. And we might not have osmosed it exactly right. So although this could be a problem, I would argue it's an opportunity for faculty development. And then I'm going to skip to that. And then the last piece is sort of best practice. And so ideally what we need to do is begin to move ourselves from satisfactory defined by what does a PGY2 do, or what, you know, how similar is it to what I do? But okay, for this skill, what are the components of this skill that are evidence-based that ensure that a patient gets good care? And what did or did not the learner do in that skill? So if shared decision-making has 9 elements, like which of those things happened and what didn't happen? Here's just another list of things that make direct observation challenging in terms of the quality of the workplace-based assessment. So we just talked about variable frames of reference. I alluded to content expertise. We talked about rater idiosyncrasy, like we come up with like our idea of what a second-year resident's able to do. People prioritize different aspects of performance. So maybe I'm paying attention to whether the history is hypothesis driven and focused on the differential. And maybe somebody else is focused on like whether there was patient-centered communication and open-ended questions. And both are important. We probably have variable definitions of competence. We make lots of inferences. And let me pause on this one for a second because it's really important. We make inferences all the time. And let me give you an example. We showed a video to faculty where the resident was breaking bad news. And we scripted the resident so that the resident was standing up and their arms were crossed and they were like leaning against a wall with like the patient on the other side of the room as they broke bad news. And when faculty assessed this resident, we got everything from this person lacks empathy, to this person's really anxious, to this individual must never have broken bad news before, to this is a knowledge deficit around knowing that you're supposed to sit down. So the behavior was standing up with crossed arms, breaking bad news. But people made a lot of assumptions about what that meant. And when it came time to give feedback, they didn't say, you know, I noticed that you were standing during the encounter with your arms crossed. Shut up, stop talking, see what the person has to say. They would just be like, wow, you were really anxious. Well, like, you could imagine that if you're the learner and you weren't feeling anxious, already you've stopped listening, right? Because this faculty member doesn't get you. So we make a lot of inferences. And then the other things that get in the way of good workplace-based assessment are rating errors, first impressions or contrast effects. This is the idea that, let's say you're working with an average medical student, and the last medical student that you worked with was like a rock star. Your average medical student like doesn't look so hot, versus if the last medical student you worked with was really, really struggling, all of a sudden this average medical student looks pretty good. So that's contrast effect. And then there are lots of contextual factors that also get in the way. So what I'd like to do is spend the rest of our time really kind of leaving with some concrete strategies for how to improve the frequency and quality of direct observation, and hopefully some things that you guys can do as you think both about your careers as medical educators, but even things you could do now as you're working with, you know, your interns and or medical students. So I think that the first piece of this is getting buy-in from learners. Direct observation shouldn't feel like something we are doing to learners. It should really be something that we are together, like doing together. So what does that mean in terms of how do we implement that? So I think we have to do a much better job of explaining to learners why direct observation is important. And I think we have to do a much better job of saying, like, if we want to be master adaptive learners, if we want to develop expertise, we can't do that without feedback. And feedback isn't going to be valid or useful or specific if it's based on proxy information, if it's one-off. So I've got to get in there and watch you doing. The second thing is that I think we need to provide our learners with more self-efficacy and engagement in driving goal setting and in driving the observations. Particularly if I'm going to be working with a learner 4 times in 2 weeks, if I am driving the agenda, I have no idea where they are, what they're good at, what they're not good at. So, you know, although self-assessment isn't always accurate, I think we have to do a much better job of getting our learners to say, here's what I'm working on. You know, here's some of the feedback I've gotten in the past. And what I would love is if you could observe me doing X, Y, or Z, because I'm interested in feedback about blah. I think we could create and normalize this if we provided more examples of skills that we know that many individuals need to develop. So, you know, I think it's helpful to say to a starting off clerkship student, I know that most starting off first block medicine clerkship students are working on the following skills. Like, these are the things you're learning. Which of these should we focus on? And then that normalizes it, right? And then the last piece is I think we have to have conversations about, again, this gets back to this tension of feedback versus assessment. Many of you, I'm going to make the assumption, we're all fairly high functioning individuals. We have perfectionistic tendencies. Most of us along our lives have liked to get good grades and do well. And that doesn't end in medical school. And so what can happen is that when we get observed, we can start performing, like not doing what we would normally do so that we can look good. And what I try to convince learners of is that that's just not helpful. What you really need to know and what you really need is feedback about your authentic behaviors, right? Like, and I do this a lot with the residents in particular, like, you need to know that the shortcuts you take are the right shortcuts. And so the more you can act authentically, the more I can give you feedback that's actually going to be valuable to you. So this gets to this idea, and you guys might have talked about this in your program, this idea of being mastery-oriented or performance-oriented. A performance-oriented individual, which can be associated with a fixed mindset, is like, my goal is to just like look good. So somebody who has a performance-oriented mindset isn't going to say, here's what I'm working on, because they just want to show you their best side. As opposed to somebody who's mastery-oriented or growth mindset, who sort of recognize that there are areas to work on. They're willing to share that with you so that you can together work and improve. And so I think where we are is like, we can all talk to the cows come home that we should all have like mastery-oriented learners with a growth mindset. The reality is that we operate in a very performance-oriented culture, right? And so I think that one of the challenges we have in medical education is, how do we truly create learning environments that are mastery-oriented and growth mindset? And so here are ways that I also try to engage learners in sort of direct observation so that they feel like it is happening with them and not to them. Many of these things I've covered before. So like, I would come into resident clinic when I would precept, and I'd be like, you know, who are the most challenging patients on the schedule today? You know, that patient that is very difficult to redirect, the patient who perhaps has like chronic pain and or has, you know, a PAM positive review of systems. Like, that's where my observation could potentially be helpful to you, not the straightforward like strep throat. Again, what are you working on? What do you want me to observe? What is it that you're wanting feedback about? And I think this creates, you know how we talk about in patient care, like the therapeutic alliance? I think these kinds of things help to create the educational alliance. Okay, let me just move my little toolbar because I cannot see the title of this slide. So the other piece of this going well is that observation will typically be more successful when there is a longitudinal relationship between the observer and the person who's being observed, right? Because it creates, there's investment, there's trust, there's credibility. So the degree to which it's possible to observe individuals who you are working with over time is always optimal. You also get to then see the feedback that people have incorporated, which is always really nice. And because you have been giving feedback and you're seeing improvement, you can actually give learners more responsibility, which can promote their autonomy. So there can be like a benefit to the observation. And then the other piece is that there's a lot of literature about the more that observation and feedback happen in this like longitudinal relationship, the more likely it is that somebody is going to find the feedback as credible and as trustworthy. And you can imagine that if the goal is to have the feedback be heard, listened to, incorporated, and acted upon, it has to be perceived as credible and trustworthy. And so, you know, you can all think of times where you've worked with somebody one time, they gave you feedback, and you're like, that's one off, and like you sort of discarded it. And this is a really, I think, also big challenge in our learning environments, because there is such a discontinuity now between learners and their teachers because of like shortened rotations and shifts and the like. But the more that you can build this in, the better off it is. Okay. And then I like to share Maslow's hierarchy. I don't know if in your track you've talked about Maslow's hierarchy, but it's a framework for how to think about meeting individuals' needs. And the reason I think it's relevant is that our goal is to have our learners self-actualize, right? Like, we want people to achieve their full potential. And what Maslow's hierarchy says is that in order for people to achieve their full potential, you need to meet both their basic needs and their psychological needs. So if you have a learner that's hungry, that's tired, where they don't feel like they're part of a team, they don't know where to put their belongings without them getting stolen, like, that's all distracting and you can't be your best possible self. So even if you're working with somebody for a short period of time, I try to get people to think about, how can I help to meet my learner's basic and psychological needs so that the learning environment feels safe, so that we then can get to the important work of observation and feedback. So like making sure there's biologic breaks on rounds. When it's non-COVID, like bringing in some snacks, asking people their names, telling them where they can put their belongings, having an icebreaker each day as part of the team so that people are people, not just like the medical student, but you know, what are people's interests and hobbies and what do they care about? Okay, and then the other thing as an observer that's really important is to try to minimize interference between the learner and the patient. And there's a strategy called triangulation. So what you can see here is like I'm the observer, here's the patient, and here's the resident. And I'm sitting in the peripheral view of the patient. I can see the patient's face, I can see the learner's face, but the patient is really forced to look at the resident. And so this is triangulation. So just thinking about where you put yourself in the room is really important. When you're doing observation, you want to be a fly on the wall. So if you're like scrolling through your phone and tapping your pen and like shuffling through papers, it's distracting, right? And it's going to take away from the learner and the patient. In order to really maintain the focus between the patient and the learner, you want to minimize eye contact with the patient as much as possible. Not to the degree that somebody's going to think you're a sociopath, but like enough that you're not like being distracting. Now, even if you are really trying to avoid eye contact with the patient in a socially acceptable way, the patient's going to know that you're like the senior person in the room and they're going to look at you. So when they start looking at you, all you need to do is look back at the learner and the patient will automatically redirect, or you can verbally redirect. You know, that's a great question, Mrs. Smith. Dr. Jones, what are your thoughts about that? And it takes it back to the learner. All right, so those are some strategies from the learner side, which is one, you're gonna get learner engagement. Two, you're gonna like triangulate your body and you're gonna try to have learner-centered observations. Okay, you all said that time, exclamation point, exclamation point, exclamation point was like one of the barriers. So the strategy to overcome that barrier is to think of direct observation as snapshots. So what happens is when we think of observation, we're like, oh my God, I gotta watch a whole history and a whole physical exam and watch them talk to the patient. And like nobody has time for that. What I would like you to think about is how can you watch somebody for 3 to 5 minutes? And I promise you in 3 to 5 minutes, you will make plenty of observations that you can discuss in feedback. So the goal is to figure out what are some of these observation snapshots. And the idea is that they should be snapshots that help the learner and help the patient, ideally. So can you guys think of some brief ways that you could observe a learner with a patient? What are some brief observations you could make? No more than 5 minutes. Throw them in the chat for me.
What thoughts do you guys have? Counseling about a new medication at bedside.
One of my favorites.
The one that comes to mind for me is asking about code status when admitting a patient in the ER.
Awesome. I see observing part of a physical exam in somebody with new shortness of breath. Great. So you guys, you get the idea. So what I would encourage you to do is it's hard to think of these in real time, but if you can just think to yourself and have your running list of what are some good snapshots, and trust me, as you begin to think about them, you develop more and more of them. Some of my snapshots are here. So I love watching agenda setting in the ambulatory setting. It's a snapshot because honestly, most interns and residents don't agenda set, so I'm out of the room pretty quickly. Part of a history, joint exam, I like doing that. And then you guys came up with some of the counseling ones like code status or even consenting per procedure. Even a great direct observation is watching somebody talk to a patient about like the flu shot or the COVID vaccine and watching how they engage with a patient who has vaccine hesitancy. So here are some examples of my snapshot. And then the key is sometimes you can have snapshots that like don't take additional time. So if I say to my residents in clinic, if you see a patient with knee pain, take the history, don't do the physical, come get me. and we're going to go back and you're going to do it together, it saves time because they're not presenting the joint exam to me. They're not doing it, coming and getting me, talking about it. We have to go back. I've got to do a second one to figure out what's going on. We just do it all right there. So that's a great example of like a 2-for-1. And then the way to make this work is to realize that once you've observed 3 things that you want to talk about, you can leave the room. So you have to set it up that way with the patient. I'm only going to be in the room for a minute or 2, you know, but I'll be back towards the end. But once you've identified 3 things, you're done. Walk out. Okay, and then the last piece, just to finish up, is rating quality. And so this is where I have spent a lot of my time in terms of research, trying to think about how do we improve the quality of the observations that faculty make. And in the literature, a lot of the effort has been on trying to fix the tool. People think if they make a better assessment form, they're going to improve the quality of the assessment. The other strategy is just to sample, like realize that, you know what, people aren't very reliable. So if we just sample enough, we'll get to a picture of the truth. And what I kind of feel is that really where the money is rater training, faculty development, and training the assessors. And one technique that we do a lot in our faculty development is something called performance dimension training, which really kind of answers the, what the hell are we looking at in this cartoon? So we've got like a cat and a dog looking at a wall. And I don't know how many of you have done observation, but like, gosh, in the beginning when I did it, I was like, what is it I'm supposed to be paying attention to? So this helps faculty to figure out what it is they should be paying attention to. And so the way that it works is that you give a skill like starting a medication, to use one of the examples that you guys came up with. And you say, okay, let's imagine, I want you to picture expert starting a medication. What are the things that need to be said or done, and in what way? And the group develops a shared mental model around what does expert starting a medication look like. And when you do this performance dimension training, what we've learned is that faculty feel like they are better at direct observation. They feel like they're better at giving feedback. And they actually often feel like it's a nice refresher for them in terms of their own clinical skills. And then the last piece of the training is to improve the quality of the judgment. So I observe a learner, I make all of these observations, and then somebody gives me a rating form and I've got to like circle a number on it. And this gets back to the idea that there are these variable frames of reference. And so what we do in our training is we say, look, at the end of the day, it's not that I really care about like, are you doing what I do? Or are you doing what a second-year resident can do? But like, where is this in the context of what somebody needs to be able to do for independent practice? And that's the gap. And so that's how you start to do some standard setting. And then increasingly what has assisted with this, and I don't know if you guys use this at your institution, are sort of either supervision or entrustment-based scales, where you move away from the normative to sort of how much help does a learner need with a task, or how much supervision is it that they need. The reality with this is these scales do not solve all the problem because everybody has their own supervision style. And so at the end of the day, you still have to have a shared understanding of what is competent. So just to kind of summarize so that there's a few minutes left for questions at the end, what I've hoped that I've shared with you today is a little bit about like what is direct observation and why it's important. We talked about 3 strategies to engage learners. One is the importance of learners setting goals. 2 is building those longitudinal relationships and thinking about Maslow's hierarchy. And 3 is engaging learners by not undermining them, by thinking about like how you act when you're doing the observation. To address the issue of time, we talked a little bit about observation snapshots and leaving when you've observed 3 things. And then I just left you with a little bit of like, there's also a lot of work that needs to be done with respect to faculty development to improve the quality of the assessments.